Well, welcome to the Supporting Client Health and Wellness class presented by the Far Northern Regional Center's clinical team. My name's Jen Badger. I'm a nurse in the Reading office, and I can introduce our other team members on today. We have Nellie Camarena is our nurse out of the Chico office.
Hi, everyone.
And also Katie Taylor, who's our nurse, another nurse who works in the Reading office.
Hello.
So we're going to go ahead and get started with the class. Today's class is on Clozaril and other high-risk medications. The reason why we decided to do this particular topic is because we have had a pretty significant number of incidents with individuals who are on Clozaril and other high-risk medications. And so we just feel like it's an important topic to go over so that we can all be aware of what high-risk medications are and how we can best ensure that our clients don't suffer any negative outcomes on those meds. So first, I'm going to just very briefly go over what high-risk medication classes there are, and then we will dive into discussing Clozaril, or also known as clozapine. And then we will talk about anticonvulsants and lithium. And then we have some final tips and takeaways. And then hopefully at the end, we'll have some time for discussion. And we can go ahead and you can unmute at that time, and we can just openly talk about any ideas or concerns or questions that you have. All right, well, high-risk medications are drugs that bear a heightened risk of causing significant harm when used in error. These are medications where going without the med, like a missed dose or accidentally getting more than what is prescribed, can cause significant harm. And that can be anything from, a fall and injury to a seizure or coma or death. So we will go into kind of finer details on those, but there is, if you look online and you search high alert medications, you can find lots of information about these medications that I'm going to talk about here in the first couple of slides. But just in case you weren't aware, this is the definition of a medication error. And a medication error is any error that occurs in the medication use process. And that's all the way from when the doctor prescribes the medicine to when it's being transcribed from the prescription to the actual label and what the pharmacy is dispensing, to when the medication is being administered or taken by the client. It includes whether the client is adhering to the doctor's orders, and that is also another word for adherence is also compliance. And it also includes monitoring. So part of what you all do in providing care for our clients is you keep an eye on them and provide some supervision and monitor for any negative side effects they may have or problems they may have with their medications, or whether or not the medication is working or not. So an error can occur in any one of those steps. And with these particular medications, an error can, of course, have really devastating consequences. So this is a basic list of medication classes that are associated with the potential for causing significant harm. The first is beta blockers. We've talked about these before. Beta blockers are used to control blood pressure and heart rate, and they can, in some circumstances, cause what's called a heart block. And that's where that risk of harm is high because they can slow the heart rate down too much. Anticoagulants, those are blood thinners. So I think you can understand where there's a risk there, and that if the blood is too thin, if you will, it's not going to clot. You run the risk of bleeding. And then if with an injury, you can have excessive bleeding, but you can also have like spontaneous bleeding if if a person is anticoagulated far too much. Lithium, which we're going to talk about a little later, is used as a mood stabilizer for individuals with bipolar disorder or schizoaffective disorder. Sedatives can be very dangerous in that some people are affected differently than other people, and sedatives can decrease a person's mental ability to stay safe, and they can also inhibit respirations to the point of not getting enough oxygen. Narcotics and opiates can have devastating effects at too high of a dose, similarly to sedatives. Anticonvulsants, those are medications that are taken for seizure disorders or epilepsy, but they're also used as mood stabilizers for individuals with mental illness. And those can cause problems. We're going to talk about those today. Potassium, you may have heard somewhere or seen on a TV show or a movie, potassium in very high doses can cause cardiac arrest. In very low blood levels, potassium deficiencies can be very dangerous as well. Diuretics, which help the body get rid of extra fluid and water, can lead to severe dehydration, low blood pressure. Epinephrine is used primarily, we see it for people who are not in the hospital using an EpiPen for like anaphylaxis or something, but epinephrine can be dangerous if it is not used correctly. Hypoglycemics or insulin, which are taken for diabetes, can, if too much is taken or the person reacts strongly to medicine in this group, they can have dangerously low blood sugar. Chemotherapy can cause, significant damage to the organs and complications. Chemo, as you are aware, I'm sure, is used for cancer treatment. Antiarrhythmics can cause significant heart rhythm issues, blood pressure issues. Antipsychotics can be very dangerous. We're going to talk about Clozaril today. Clozaril is an antipsychotic. Antihypertensives, for the same reasons that beta blockers are. You can have too low of a blood pressure if these are taken in excess. And benzodiazepines run some of the same risks as sedatives do with hypoventilation or not breathing deep enough. We don't have time today to go into all of these. Obviously, we've just chosen a couple, but in the future, we may do more classes on some of these other medication groups. All right, so let's go ahead and dive into Clozaril. So Clozaril, otherwise known as clozapine, was the first atypical antipsychotic that was developed. It was actually pulled from the market in 1975 because it was found to cause agranulocytosis in some people, and it led to some patient deaths. However, studies showed that clozapine was more effective than any other antipsychotic for the treatment of schizophrenia. So after some work and being able to look at these studies and see that it was so much more effective, the FDA did approve clozapine for the treatment of treatment-resistant schizophrenia, also called refractory schizophrenia. So basically, someone who's tried some other medications and they didn't work, then they will go ahead and try the clozapine. But because of the risk of agranulocytosis, the FDA wants doctors to try some other medications first. One special indication with clozapine is also that it reduces suicidal behavior in people with schizophrenia or schizoaffective disorder. So for individuals who struggle with chronic suicidal ideation and suicide attempts, then it is possible that clozapine would be the medication of choice for those individuals because it is shown to reduce that. Clozapine is also sometimes prescribed for schizoaffective disorder, bipolar disorder, severe OCD, childhood psychosis, and agitation related to Alzheimer's dementia. And as I mentioned, clozapine should be considered after trying and failing 2 other antipsychotic medications. I recently went to a conference where they emphasized this, that once someone has failed 2 other medications, that they should be trying clozapine because with monitoring and supervision, they found that it's very effective and can be safe. So clozapine comes with some warnings. And then the top warning is agranulocytosis. And this affects about 1% of patients who start on clozapine, which 1% may sound small, but 1 out of 100, I mean, it's kind of a big number when you think about, well, how many people, are on clozapine, and if that 1 out of 100 ends up with this condition, then it just highlights how important it is to be keeping an eye on them. It's much more likely that it occurs in the first few months that they're on clozapine, but it can happen at any point in treatment. So even folks who've been on clozapine for a long time can develop agranulocytosis. And we will talk more about what that is on the next slide. Clozapine can also lead to other blood disorders, such as eosinophilia, leukopenia, and neutropenia. Agranulocytosis is technically a type of neutropenia. It can cause seizures. It can also cause cardiac issues such as myocarditis and pericarditis. Clozapine can cause low blood pressure, particularly orthostatic hypotension. And that's when someone changes position, like getting up from a seated position to standing, where their blood pressure drops. They can get some slowing of the heart rate as well, and then have syncope, which is the same as fainting. Clozapine has also been associated with respiratory arrest and cardiac arrest. And there is a black box warning for increased mortality in elderly patients with dementia. But this warning is actually on pretty much all antipsychotics. It's just kind of commonly known that antipsychotic treatment in elderly individuals with dementia can lead to, or appears to lead to, a higher rate of mortality. So agranulocytosis is severe neutropenia. This is potentially life-threatening, where the absolute neutrophil count is less than 500. It increases the susceptibility to serious and potentially fatal infections because neutrophils fight infection in the body. And here's a great little animation. This is what one of your neutrophils looks like. It's pretty good size. It's in the group of white blood cells that it's not a white blood cell, but it's a neutrophil. But it does the same sort of thing in your immune system and fights off infections in the body. And what we don't probably think about very much is that our body is actually fighting off the potential for infection all the time. There's bacteria all over in our environments. We're constantly being exposed, but our bodies usually do a good job of fighting them off so that we never actually get sick. But when this absolute neutrophil count is so low, it can be very likely that somebody ends up getting a severe infection. And as I previously mentioned, it does usually happen in the first month of treatment, but the first 6 months are considered the highest monitoring period to make sure that the person who's on clozapine is not having this condition develop. It's been shown to not be dose dependent. So it doesn't matter if the individual is on a low dose or a high dose. It doesn't seem to be associated with dose. It's really just being on clozapine, which is why when someone does develop agranulocytosis, most of the time a doctor will not restart clozapine. They will have to use something else. And the symptoms here of agranulocytosis are going to be similar to that of sepsis or a systemic infection. The hallmark symptom is a high fever, but it might also include weakness, low blood pressure. The person may develop sores in their mouth or their throat. There's low blood pressure again, sorry. A rapid pulse and possibly trouble breathing. And this is a medical emergency. So the lab monitoring of individuals who are on clozapine is initially every week for the first 6 months. Then it goes to every other week for 6 months. And then it goes to every 4 weeks, and that is forever. They never spread out the labs more than that. It's every 4 weeks after the first year. But what is important to realize is that when somebody misses a lab or they go off of clozapine, they have to start all over again. Typically, clozapine is started at a low dose and then titrated up over a couple of weeks to a month. And if an individual misses several days worth of their clozapine, they have to start over at the lower dose. And like I said, they have to go back to doing weekly labs for 6 months. And as you know, or can imagine, that's a really heavy requirement to have of anyone, let alone our clients who oftentimes struggle with going to the lab. Maybe they have anxiety about going into doctor's offices. Perhaps the person may have trouble just allowing blood to be drawn. So imagine going through all of the weekly labs and then the every other week labs, and then going to your 4 weeks. It'd be such a relief. But then if there was a problem, having to go all the way back and start over. One of the ways that the FDA ensures that these labs are being done and being checked prior to dispensing medications is they have a program. It's an online program called REMS, R-E-M-S. And the way it works is the pharmacies have to be certified to dispense clozapine. They have to be signed up with REMS. They have to actually obtain a copy of the lab result before they can fill the medication. And they only fill the medication with enough time to get through till the next lab. So if the person is on weekly labs, they're going to get 7 days worth of clozapine. And then they'll go back and get their lab. And then when the results are in, they'll get their next 7 days worth. And so there's a very strict schedule to this. When on weekly labs, they may go get their labs drawn on a Monday, and then the results maybe are always back by Wednesday. So on Wednesday, they pick up their 7 days, and then they go into the lab on the next Monday. They pick up their 7 days on Wednesday and keep going in that cadence. But any missed days or delays in getting the labs drawn, delays in the results being obtained by the pharmacy, or delays in the pharmacy dispensing is going to stretch out that time. If the lab isn't drawn and the results aren't received, the clozapine will not be filled. So the person will go without the medication and then again have to restart back on this program. So what are some other side effects of clozapine? This is by no means an exhaustive list, but these are the ones that I wanted to highlight for you. One of the common side effects are metabolic changes, and that's generally slowing down of the metabolic rate. Some individuals will gain weight. They may even develop diabetes type, similar type conditions. They could even develop diabetes after a while, but that's something that needs to be kept an eye out by staff to report to the physician. Hopefully the physician's office is going to catch those things as well, but they don't always. You know, sometimes there's months go by before they see someone again, and if they've put on quite a lot of weight, it's oftentimes up to the individual or their caregivers to inform the provider, you know, hey, it looks like they've gained a lot of weight, and then hopefully they can address that. Gastrointestinal hypomotility. Hypo means low or slow. Motility is movement. We're going to get into this one, so I'm not going to stay on that right now. Nighttime drooling is very common with clozapine. They call it wet pillow syndrome. Sometimes folks will wake up in the night, there's a lot of drool on their pillow. Sometimes drooling can happen during awake time too, but for most folks, it's a nighttime thing. Clozapine is usually taken in the evening, and so it can be sedating and people sleep really hard, which is also why bedwetting is not uncommon. So just be aware if you work with clients at night who might be taking clozapine, if they have an accident from time to time, that could be an effect of the clozapine and not necessarily a physiological issue that they're having, like related to their age or developmental disability. Falls can happen, and that usually has to do with that orthostatic hypotension that we can see. And then somnolence. And somnolence is just being kind of flat, not really being very happy, not really being very active. Some people describe it as feeling like a zombie, but that can be a pretty common side effect. And oftentimes that's a complaint that patients will have when they're taking clozapine, is they don't feel like themselves and just kind of lack the enthusiasm for life that they had before. So let's talk about gastrointestinal hypomotility. I know we have talked about constipation a lot, but I just want to dive into this in particular with clozapine, because it is extremely common. And not only that, but constipation alone is constipation, but constipation related to clozapine seems to be particularly severe and can lead to intestinal obstruction, fecal impaction, or even paralytic ileus. Clozapine is contraindicated in individuals who've had paralytic ileus. It's something where if that's in someone's history, they should probably, make sure that their psychiatrist is aware, or at least understands that clozapine may not be a good option for them. And in addition to the monitoring of those labs, it's equally important to monitor bowel movements. For these folks, their gastrointestinal hypomotility is going to increase with higher clozapine levels. So unlike agranulocytosis, which is not dose dependent, the gastrointestinal effects are dose dependent. So the higher the doctor goes up on the dose for the individual, the more likely they're going to have severe constipation. Clients should be advised to report constipation to their doctor immediately. And this is really important because normally that wouldn't be the advice, right? Normally we would have, lots of things to try and, dietary changes, activity, and all of that stuff that we encourage people to do. But with clozapine, it is really important that if somebody hasn't gone for a few days and nothing they're doing is working, that they let their doctor know. And the reason for this is because it's important to catch any kind of intestinal obstruction or impaction early before it becomes a serious emergency and leads to any type of severe outcomes, such as having to have part of your bowel removed or having to have a colostomy placed, or death, which of course would be the worst outcome. But this is just super important. The doctor may even adjust the clozapine dose for a little bit to try and see if that is helpful. Constipation needs to be treated immediately, and it should be noted that the reported fatality rate for severe clozapine-induced constipation is 20%, which is really high. That's like 1 in 5 people. So it highlights how important it is to stay on top of this with anyone who's taking clozapine. So how do we prevent constipation? Quick review. I'm not going to spend a lot of time on this slide. You guys have heard this all before. But basically, there's 2 different areas we're going to look at: non-pharmacological, pharmacology, pharmacy. Think of that. That's like non-medicine. And pharmacological, that's your medication. So the main ways to prevent constipation in day-to-day activities is increasing that water intake. The more water is in your bowel, the softer your stool is, the easier it is to move. Avoid caffeine, and primarily this is because caffeine is dehydrating. It causes you to pee out more water, and the more dehydrated you are, the more constipated you're going to be. Increasing physical activity or exercise, getting up and moving around, going for a walk is a great way to get things moving. And increasing fiber intake slowly. You shouldn't just go from hardly any fiber to a ton of fiber. That can actually block things up. So you want to increase that fiber intake, though, to help bulk up stool and make it easier for the bowels to move. Pharmacologically, we have the options of laxatives, and they work in a variety of ways. Most laxatives are available over the counter. However, as you are probably aware, you will need a doctor's order or prescription to be able to administer laxatives in a day program or a licensed residential facility. Laxatives fall under 4 main groups. The first one is osmotic, and those are medicines that pull water into the bowel to soften the stool. Fiber laxatives, those are bulking, so it causes the stool to be larger and more manageable from the bowel's perspective of trying to move the stool through. A stool softener, which is a small, usually a gel tab that helps to retain more water in stool and keep it soft. And then intestinal stimulants, and these can be oral medications, or it can also be in reference to suppositories such as Dulcolax or Bisacodyl or glycerin. So these are all different laxatives that can be taken to prevent constipation. It's really important too that we are that assisting clients with tracking their bowel movements. Some clients are living independently, and so they may just need a simpler version of this to mark down when they go. Maybe just write the date and that they went. But it's really, really helpful if you know if the bowel movement was it large, was it average, or was it very small? And then the consistency as well. So how do we treat constipation? It is really important with individuals who are on clozapine that they are actively treating their constipation after 2 days without a bowel movement. And this requires some education to clients who are taking clozapine. you can almost guarantee that their doctors are going to be talking to them about this. And we want to reinforce that education and teach them the same thing. And frequently reminding is how we make this something that they are going to think about from day to day, and then they will be keeping an eye on how often they're going or how long they're going without a bowel movement. Having them, again, either you're tracking their BMs on a log or you're having the client track their BMs on a log. This is especially important when there's multiple staff people who are working with the client. You know, we all work shifts and we all have days off. And if it's not written down, then the person the next day or the day after that, or the day after that, they aren't going to know what happened, right? And then we want to be able to, when we know or believe that it's been a couple of days since the individual's had a bowel movement, we want to make sure to remind them or assist them with taking their laxatives per their doctor's instructions. People who are constipated should avoid fiber laxatives, particularly constipated from clozapine, because the issue is not that they need more fiber. The issue is that their bowel is not contracting and moving stool through. It is hypomotility. Fiber laxatives can actually make this worse once constipation has set in, because now the bowel is going to be more distended from all that fiber, and it's going to have an even harder time contracting and moving the stool through. Now, that doesn't mean avoiding fiber prior to being constipated, right? We talked about that with prevention. It's okay to use fiber. But once a person hasn't gone for a couple days, it's a good idea to avoid fiber laxatives. In general, if a laxative doesn't work after 24 hours, a second laxative can be added. And then if 24 more hours go by and still no BM, a third laxative can be added. This is what we call a bowel protocol, where you go from, you know, okay, let's do this. We're going to do Miralax because it's been 2 days. And then the next day, if they haven't gone, that might be time for a suppository. And then if we are getting to like 3-4 days, it's probably time to get in to see the doctor. When to go to the ER. Anytime a person is having moderate to severe abdominal pain or discomfort that lasts more than an hour, and that's because when a person's constipated and their bowels starting to move things, you know, there can be some cramping that happens, but it shouldn't last for an hour or more. If somebody's having severe pain and it's not going away, they need to go to the ER. If the abdomen is swollen or distended or bloated, especially if it's hard, that is an emergency and they need to go to the ER. Overflow diarrhea. I know we touched on this previously when we talked about constipation and bowel obstruction, but I will just say that this is real. I just had an experience with an individual in the last year where the complaint was that they had diarrhea. And the diarrhea wouldn't go away. And it was just liquid stool, it was just liquid coming out. And it was repeatedly stating this. And what ended up being discovered was that the individual had a severe impaction and bowel obstruction. And what happens is that you have the stool that's in the colon, and it's all hard because it's been sitting there for days. And so the colon pulls water out of the stool, makes it even harder. And so upstream, because the person's still eating and drinking and stuff, at least some, liquid stool that hasn't even necessarily gotten into the colon yet, it's got to find its way in somehow. So it kind of just moves around the hard stool, and then it just comes out as liquid. And so that's called overflow diarrhea. And it's a very tricky thing, because if someone tells you they have diarrhea, one of the last things you're going to think is, oh, you must be constipated. But in fact, it is a sign of a serious constipation problem. So if that happens, then definitely go to the ER. Any real sickness or throwing up, especially if the emesis smells like stool, that is an emergency. That means things are way backed up, like all the way up, and that they need to go like right now. So super dangerous. And then any symptoms of sepsis, which we have gone over sepsis previously, and you may recall, includes symptoms such as fever, low blood pressure, fast heart rate, difficulty breathing, and mental confusion. So for any of these reasons, an individual would want to seek help at the emergency room. And of course, especially if they already have been, recognizing that they have been constipated for a couple of days, then you really know, like, oh, we're in trouble. Of course, all of these would indicate trouble, but I think you get what I mean. Okay, before we move on to anticonvulsants, I just want to take a second if anyone has a question. Nope, okay. All right, so let's just talk about anticonvulsants and lithium. These are medications you might even see prescribed along with clozapine, because anticonvulsants are used oftentimes as mood stabilizers. People who have epilepsy can also require clozapine for an antipsychotic. And lithium is a mood stabilizer. That is its only use, and is used for folks who have bipolar disorder or schizoaffective. But we have a lot of clients who are on anticonvulsants just for epilepsy, and these medications are high risk regardless of what they're being taken for. There's a long list here. You've probably heard of some of these. We have Dilantin, Tegretol, Depakote, Depakine, Lamictal, Trileptal, Topamax, Neurontin, and Gabatril. And those are the most common anticonvulsants that are used today. So I threw this on here. I love this graph. This is just showing that there is a therapeutic range. It's between the gold dots, and it shows when somebody takes the medication, and here they're taking their first dose, and their blood levels are going up within this therapeutic range. And then they take their second dose and it goes up. And eventually they get to where they're just staying in the same zone. And that's called the steady state concentration. And this is the good place to be, right? The medication should be working. It's at a safe concentration in the blood. So the problem that we see, particularly with anticonvulsants and lithium, is the risk of going up here into this toxic range. And that can happen with an extra dose, like an overdose that's given. It can also happen if the prescription is for a dose that is higher than what the person's body can metabolize in a timely way. And so, you know, a lot of times folks will start on a medication for the first time, and maybe they're a little more sensitive. And so they may end up going into this toxic range, even though there was no error, if you will, but then the doctor needs to adjust it. If a person misses a medication dose, then they can drop down below the therapeutic range into what we call subtherapeutic, where the medication is not going to be doing what it's meant to do, or it probably won't be. And then they run the risk of having an increase in symptoms of whatever condition they're taking it for, which in the case of an anticonvulsant may be having seizures, or it could be severe mood fluctuations, mania, or depression. And with lithium, you would see something like that if it was in the subtherapeutic range. So anticonvulsants, there are some risk factors to becoming toxic. Individuals who have liver disease or kidney disease, depending on the medication, if the medication is metabolized in the kidneys and the person's kidneys don't work all that great, then their body's not going to eliminate it fast enough. Same with a medication that's metabolized by the liver. Liver disease can make that medication stay in the body longer, and generally the solution to that is to use a lower dose. Malnourishment, if someone's very underweight, if they are really thin, they're not getting enough nutrition, it's possible that they can also end up with too much medication in their body. Low albumin levels, that has to do with protein nutrition. Certain metabolic disorders where they're just not metabolizing things as they should. There are some congenital conditions that can put people at higher risk for toxicity. And those typically have to do with the way that people metabolize drugs. Taking more than one anticonvulsant can increase the risk, because now the kidney or the liver have to process multiple anticonvulsant medications. So it might not be as effective. And some other medications that I'm not going to go into today, but these are all risk factors for anticonvulsant toxicity. And then what are the symptoms? So these are the top 9 symptoms that are reported in individuals who are toxic, meaning they have a very high level of the medication in their blood. Unsteady gait. So a gait is how someone walks. If they are, if this is a person who normally can walk really straight and great, and all of a sudden they're having trouble walking, maybe they're feeling dizzy, maybe they're real nauseated and throwing up, they might be having weakness. Oftentimes they'll be really sedate or drowsy because you've got more of that sedative side effect than normal because the level's too high. Sometimes headache. Usually they will have some confusion. Double vision is very common. and then slurred speech. So anytime somebody has these types of symptoms, they really need to get checked out. And ideally, they would go to an emergency room where they can do a lab level and find out if they are toxic from their medication. So lithium toxicity, there's actually two different scenarios here. If somebody overdoses, like they double up on their medication, or maybe have made a suicide attempt by taking a bunch of lithium all at once, the symptoms can be dizziness, nausea, stomach pain, throwing up, slurred speech. They might have twitches in their muscles and tremor. They could even go into seizures or a coma. But it's a little bit different when someone has been on too high of a dose over time and the level is slowly building up in their system. And I think part of this is because the body finds ways to compensate. And so instead of having like these symptoms, which are sudden and severe, what can happen is over time, they develop these problems, increased reflexes, a tremor, their speech is slurred, movement disorders, maybe they're having trouble remembering things. They could be having problems keeping salts in the body or developing electrolyte imbalance. They could even have signs of psychosis. But the worst of all of these is going into kidney failure. And this is a very possible scenario, and it's just highlights how important it is that physicians are checking lab work and keeping an eye on a person's lithium level, even if they've been on it for a long time. So therapeutic drug level monitoring is where they draw blood and they just look at how much of that medicine is in their blood at that time. And it's just making sure they're not in the subtherapeutic range or the toxic range. And if the level does come back really high, the prescriber is going to probably lower the dose. They might even stop it for a little while so that the blood level can come down. And then when they check the blood again and it's not high anymore, then they may restart it at a lower level or lower dose. If the blood level is too low, then the prescriber might increase the dose, but that really depends on if the person's getting some symptom relief. So if they are actually doing pretty good on the lower dose, they may leave it where it's at and not mess with it. The other thing is when they check that blood level, if it's low, they are going to probably ask, is the client actually taking the medicine? Because a lot of times when we do levels and they come back low, that's the reason why, is because they actually haven't been taking it. And not all anticonvulsants require drug level monitoring, but most can and should be checked if a person has those symptoms of toxicity. And I actually can't think of any on the list that aren't available to be checked, especially if they go to the emergency room. They should be able to have most of those checked right there. Drug level monitoring is usually done when starting a new anticonvulsant or lithium. And then if the dose is changed, so keep this in mind. So if you are helping a client at a doctor's appointment and their dose is changed, increased or lowered, they should probably have their level checked in a few days or a week. And then for routine monitoring every 6 months to a year is kind of the ongoing cadence, depending on the provider and the medication. They also may have some other labs drawn to check for the amounts of some different blood cells, platelets and red blood cells, white blood cells. They might do a complete metabolic panel to look at electrolytes. They probably will want to assess their kidney function or liver function. Some medications can increase cholesterol and triglycerides, and so that can be checked with a lipid panel. And some actually do affect hormones. So if the person's having has concerns for altered hormone levels, they may check those. Okay, so just final tips and takeaways. It's super important to educate the client and their caregivers on the importance of taking the medication as ordered, and also on the need to report any medication errors or missed doses to the prescriber right away. This is especially true with clozapine, because if a dose is missed even one time, sometimes the doctor will lower the medication dose for a couple of days to titrate them back up. And ensure that the client has their current medication list with them at medical appointments, or if they go to urgent care or the ER. Regarding side effects and adverse reactions, we want to make sure clients and their care staff are aware of what symptoms or side effects they should be watching for. We want to help the client track their bowel function on a BM log. We want to provide education on reporting any symptoms of illness or side effects to their doctor and to their caregivers right away. And educate the client and their staff on seeking medical attention for any symptoms of agranulocytosis, toxicity, constipation that's not responding to laxatives, or any symptoms or side effects that are concerning. And then lab monitoring. We want to make sure that we're educating the client and their caregivers on the importance of keeping all medical appointments. They have to go to the appointment to get those labs ordered. Sometimes renewals are needed and the doctor won't order them unless they get into their appointments. So they need to make sure that they're actually getting there. And a lot of the times that's our job to help get people to their appointments. We want to make sure they get to those lab draws, especially with clozapine. It's super important. And because it's on a schedule, we can keep a calendar of all their appointments and set reminders for the client and for the staff. So if the client has a smartphone, we should help them put those appointments and lab draw appointments in their phone so that it alerts them when they need to go. Anytime a medical appointment is missed, we want to make sure that we're helping them reschedule it immediately. And if they can't get into an appointment and they need refills of their medication or they need labs ordered, we need to help them call the office and talk to somebody, talk to a person at the front desk if you have to, and just explain that these are needed urgently. And it will basically, at least in the case of clozapine, be an emergency if it's not done. And then anytime a lab draw is missed, it needs to be done as soon as possible. Usually the lab doesn't need doesn't require an appointment. If the person misses it, they can just go in as soon as they remember. But because the lab requirements are so specific with Clozaril, it's possible that they may have to go to the ER to get their lab drawn so that they can pick up their Clozaril on time. And unfortunately, we're not going to have time for the discussion today, and I'm so sorry because I really was hoping we'd have time to chat. But If anybody has questions, I'm more than happy to stay on and we can discuss what we've gone over today. I'm just gonna